We've got a few people logged on. So this is the second lecture out of 4 regarding pharmacologic treatment of various mental health conditions. We did a talk on depression 1 or 2 weeks ago. This one's about anxiety. Next will be schizophrenia, and then bipolar disorder. Last week's talk on depression was a lot longer than this one is going to be today. A lot of information will be repeated because a lot of the medications we use for depression, we also use in treatment of anxiety, which, I mean, we're repeating the information, but I think that's helpful. I think it will help us remember some of that information a little bit better as well. Kind of like I said last time, I'm obviously just another third-year resident. So any time you feel like jumping in, adding in like anecdotes about your own patient cases, if you have any corrections to make or additions you'd like to add, please feel free to unmute yourself and jump in. Yeah, and this lecture today, unlike the last one, will not be interactive. We will be going through cases, but there won't be like a group component or answering component on your end. All right. So again, why are we doing this lecture series? A long story short, primary care physicians provide a lot of mental health care, particularly in rural settings, and we're obviously in a more rural setting. And as you move from large metropolitan areas out to more rural settings, you'll see that primary care physicians are providing the majority of mental health care or pharmacologic treatment of that. Indiana is kind of in the middle as far as mental health care goes and resources. Number 33 for prevalence of mental health disorders and number 22 for access to care. Especially during COVID, we've seen an uptick in anxiety and depression, a lot of which has been triggered by being in isolation and obviously the stress that comes with the life-threatening illness circulating around with the pandemic. All right. So as far as our objectives today, we will first talk about how to choose an anxiolytic, anxiolytic side effects, anxiolytic failure, and what to do about it, and then when and how to discontinue anxiolytic therapy. So as far as choosing an anxiolytic, your first line is going to be similar to what we'd use in depression, SSRIs and SNRIs, or just generally your SRI classes. Second line would be considered to be Buspirone and Pregabalin, which I thought was interesting. That information is per up to date. I wouldn't have necessarily picked Lyrica off the top of my head as a second line treatment. Third line listed is gabapentin, any form of benzodiazepine, Imipramine, specifically as a tricyclic antidepressant, Catiopene as an antipsychotic, Mirtazapine, and Hydroxyzine. So out of that list, again, it's kind of the anticonvulsants surprising as being options, gabapentin as being an option to treat anxiety. All right, so as far as factors you would like to consider when talking about starting an anxiolytic, you need to be thinking about the patient's age, whether they're young, old, childbearing years, whether or not gene site testing is appropriate in that patient, concomitant illnesses, history of substance use, a go-to medication, family history of illness and their own responses to medications, previously failed anxiolytics or antidepressants, and specific side effect profiles of the anxiolytic. So we'll start off by talking about adolescents. Again, last time we covered a little bit about, the risks of prescribing an antidepressant in the adolescent population. Because of this risk, it's generally recommended that you use anxiolytics or specifically SSRIs in your adolescent population only with severe anxiety. We really should be encouraging these patients to go ahead and try forms of therapy first if this is isolated anxiety without any depression. You obviously always need to be looking for depression in these patients, but if it really is truly anxiety by itself, then it's probably the best idea to hold off on medication unless they're failing therapy or they've never tried it before, or or they really are severe and need a medication initiated now. Again, in regards to the black box warning, that was drawn from a meta-analysis that combined several different studies and found that there was an increased risk of suicide attempt in the specific age group below age 24. And so when we talk about adolescents, we really are talking about anybody under the age of 24 who would potentially have that increased risk of attempt, but not necessarily of completion of suicide. Last time we talked a little bit about, what your ideal choices would be for adolescents. Fluoxetine and Lexapro or escitalopram are your ideal choices for depression. In anxiety, fluoxetine also comes through as a front runner for treatment of anxiety. So if you're trying to treat both, fluoxetine might be your best option. Other SSRIs in the adolescent population that are recommended include sertraline, fluvoxamine, and paroxetine. If they fail the first SSRI, trial a second one. And if that fails, they recommended actually on UpToDate trying venlafaxine as your next line, so an SNRI. It's a reminder that the Be Happy line is always available if you have concerns or questions about treating an adolescent's anxiety. You can always call that line and receive help from a pediatric psychiatrist, which I think is pretty awesome. And has anybody on here used that line before? Can you give any comments or feedback on it? Because I personally haven't, but I've heard it's helpful. No? Okay. All right, we'll move on. Okay, so in regards to your elderly patients, you need to be considering starting about 50% of the dose of antidepressants specifically in your elderly population. In general, this is a good idea whether you're treating anxiety or depression, starting at the anxiety specific dose or having the depression dose. The reasoning behind that is some of those medicines can cause activating effects, and they can make people feel really anxious or have symptoms of insomnia or feeling really fidgety or agitated. That can be present in your adolescence as well, and that's theoretically why there's an increased risk of suicide attempt during the initial phases of antidepressant initiation. For your elderly, as far as SSRIs go, you really want to avoid paroxetine because of some of the severe side effects and potential for a bad withdrawal. Other options, if you are considering something outside of an SSRI or SNRI, are Buspirone, Mirtazapine, and Catiopene as things that would be safe after reviewing the Beers criteria. So this next slide is about pregnancy guidance. This is similar to what we talked about last time as well. So in regards to rules for preconception counseling or during pregnancy, if your patient has really severe anxiety or they are high risk for having a severe relapse of anxiety, you should be considering continuing that medication or even starting a new medication. If they are mild or low risk for severe anxiety, you can consider doing psychotherapy alone. Again, this is because we know that some of the effects of untreated anxiety and depression during pregnancy can have negative outcomes. And so you have to compare that with the negative outcomes that may be associated with antidepressant administration or anxiolytic administration. On that slide specifically that I've got pulled up there, I have screenshots from an AIFP article and an ACOG article that I can get you access to or send you the link for. It's listed in the references on this PowerPoint as well. I think it's very important that you look up each specific medication that you're considering continuing or starting during pregnancy for anxiety and depression, and reviewing those risks that might come along with using that medication and using shared decision-making with your patients. So for example, if I were to pick fluoxetine off of my list and trialed that in a pregnant patient, you can review the AIFP article And it'll give you the references, you know, what kind of studies have been done on it, and what specific outcomes were noted. So fluoxetine, for example, in a couple of structured blind reviews showed no increased risk of minor congenital malformations, and prospective controlled cohort studies showed no increased risk of miscarriage or congenital malformations. However, there was a prospective case control study that showed increased risk of preterm birth, increased risk of poor neonatal adaptation, including respiratory difficulty, jitteriness, and cyanosis. And so what I think is helpful is to look up those medications, have that information in front of you, be able to specifically share the risks that you're concerned about with mom, and come up with a good game plan for her treatment. As far as things you definitely want to avoid during pregnancy, paroxetine and benzodiazepines, both are category D. I honestly, probably before I started doing this, wouldn't have thought of paroxetine as being category D, but it absolutely is. Along with your benzodiazepines. Benzodiazepines, just as there can be life-threatening withdrawal in adults. If you were to abruptly stop their benzodiazepines, there can be neonatal withdrawal symptoms for up to 3 months. So a pretty prolonged period of time. And if you have a mom who's chronically on benzodiazepines and taking them on a daily basis, you probably should be referring to an MFM doctor, okay? So importantly, do your homework so you can have a good shared decision-making conversation with your patient. All right. Okay, next slide is about gene site testing. So in regards to that, what it does is it evaluates different select variables in pharmacodynamics and kinetics to determine which medications would be best for the patient and most beneficial. So unfortunately, most of the studies behind GeneSight are industry funded, but they generally show good results. And psychologically, I think it makes our patients feel better, knowing that they might have a medication prescribed for them that is special and specific for them. It is free for Medicaid patients, so the risk of getting that, unfortunately, right now would be kind of a time delay and possibly initiating treatment that the patient perceives is absolutely right for them. I think because of the pandemic, testing has been slowed down several weeks, but back before the pandemic, I know we were getting test results back as early as a couple weeks, and in that case, it was an extremely helpful test to use. Okay, so as far as concomitant illnesses, there are a few things you definitely want to consider. And again, this whole idea is killing 2 birds with 1 stone. So if you have depression, obviously you want to be picking medicines that are going to treat depression, like your SNRIs. For specific anxiety disorders, if you have a phobia, and if they have very, very infrequent exposures, goodness, I don't know what it would be, something like heights. And this occurs once every 3 months or something, that they get freaked out and they have severe anxiety with being somewhere with an extreme height. You could prescribe benzodiazepines because that's so occasional. For OCD, remember that you are really going to only see benefit once those SSRIs are at a very high dose. For PTSD, it's actually been noted that the medicines fluoxetine, paroxetine, and venlafaxine are some of the more efficacious ones. And I tried to bold the X's in those different medications as kind of a way to remember that those medicines work the best. So the ones that have an X in the middle of the word might be some of your better options for PTSD. For alcohol use disorder and for chronic pain, opiate use disorder, interestingly enough, things like your anticonvulsants can help out. So your Pregabalin and gabapentin, chronic pain / fibromyalgia, kind of the same thing. And then if your patient's having a lot of itching, I once had a patient who had anxiety and also coincidentally developed hives. Hydroxyzine was a great option for her. For insomnia, you can always consider hydroxyzine, mirtazapine, and your anticonvulsants, as those all tend to have the side effect of making you drowsy. I wanted to highlight the connection between substance abuse and anxiety. So this was kind of when I was looking up anticonvulsants and their use and treatment of anxiety, there was some interesting conflicting data about, how those anticonvulsants of Pregabalin and gabapentin, how they can really help treat a lot of substance use disorders. And they can really help treat a lot of anxiety. However, they can also be substances that are abused and are particularly at high risk of being abused in patients who have substance use disorders. So I wanted to highlight that substance abuse and anxiety kind of feed into each other, and in people who do have a substance use disorder, anxiety prevalence is pretty high, up to 30%. So if you have a patient with substance use disorder, I would consider, making sure you're evaluating them for anxiety, because that could be a very strong potential trigger for their substance use. And we'll talk about this a little later, the role of anticonvulsants and treatment of those patients. So as far as a go-to medication, anything in the serotonin reuptake inhibitor class would be good. So either an SSRI or an SNRI. Neither of those medicines has been shown to be more efficacious than the other. However, I've only met one patient at this point in my residency who's struggled with anxiety alone. Usually it comes with depression. And so remember that your go-to medicines for depression, if there's no other indicator or reason to pick anything else, would be escitalopram and sertraline. Okay. All right. So just kind of a brief overview of that. Be sure you always consider your patient's age, Beers criteria, adolescents. Remember the specific side effects of the antidepressant or anxiolytic you're about to just prescribe, and we'll review those here in just a minute. Consider your concomitant illnesses like depression, your other anxiety disorders, insomnia, chronic pain, alcohol abuse, or other substance use disorders. Your go-to medicines would be SRIs in general. Remember, gene site testing is at no cost for Medicaid patients. And is a relatively low risk test to order in that case. In your childbearing years, avoid paroxetine and benzodiazepines. Sertraline is a preferred option because it's both safe in pregnancy and with breastfeeding. With a history of substance abuse, remember again to avoid benzodiazepines. You could consider avoidance of anticonvulsants because of the risk of the substance use and causing misuse of the anticonvulsant itself, or you could use it to treat the patient. It's kind of an interesting paradox. And then consider always their previously failed antidepressants and anxiolytics and their family history of illness and medicines that they may have taken and succeeded or failed with. So we're going to start off with a case here. There will be a few follow-up questions on him. You have a 75-year-old male being seen at your office at the VA for anxiety, anxious Andy. He's not very talkative and is generally embarrassed to discuss his concerns. He reluctantly completes your GAD-7 and PHQ-9, and it is apparent that he is struggling with severe anxiety and mild depression without SI or HI. He doesn't know his family history or medication history, medical history, let alone his own. He is interested in medication for treatment. His PHQ-9 came out to a score of 8. His GAD-7 came out to a score of 18. Past medical history of anemia, hypertension, he's underweight. Other history that could be contributory. He does have a history of smoking, but really no other red flags as far as like substance use. You start him on sertraline 50 milligrams. And I'm going to point out right off the bat here that 50 milligrams is a starting dose for depression, not necessarily for anxiety. And you are talking with an elderly male. So that might be a little bit too high of a dose for him. But we will follow up on that in a little bit. Other things that you would want to think about in this case, the fact that he's underweight, you could consider mirtazapine as a good option for him, especially if he's having insomnia symptoms. But that is not generally a first line or go-to for pure treatment of anxiety. He does have a little bit of mild depression, so that would be an okay option as well. All right, so now we're going to talk a little bit about anxiolytic side effects. So a lot of this will be a review again from last time. So your SSRIs are generally the best tolerated of antidepressants. They have a similar side effect profile between agents, although paroxetine generally has more severe side effects in each category. And sertraline is known to have the most GI toxicity. The most common side effects are sexual dysfunction and drowsiness, close to being up to 1 in 5 patients. And I have put a screenshot at the bottom of the screen from UpToDate that summarizes the severity of side effects with each SSRI medication. I think that is good and helpful to review with your patients before you start them on any given SSRI, to tell them, you know, this one's highest risk for GI toxicity, this one's high risk for weight gain, etc. I think that's important for your patients to know. Notably, SSRIs, they may increase the risk of diabetes, abnormal bleeding, and bone loss. So these are not medicines you would want a patient to be on necessarily long-term, although there are some specific situations in which that is warranted. They also come with a risk of hyponatremia. I've recently had a patient who has SIADH associated with SNRI use, but kind of the same mechanism as an SSRI. And again, if somebody is elderly or they have an anxiety disorder, you need to be starting the dose at about 50% to prevent activating symptoms that actually might make anxiety worse initially. And again, just a reminder of the different categories of side effects. You've got your anticholinergic side effects, drowsiness, insomnia, orthostatic hypotension, QTc prolongation, GI toxicity, weight gain, and sexual dysfunction. So now we'll move on to talking about SNRIs. So SNRIs have a lot of similar side effects as SSRIs, but there are some notable differences. One being that chronic use may lead to significant weight gain, over 5 kilograms actually. Due to the effects on norepinephrine, it might raise your blood pressure, and you should always have caution in patients who have acute angle closure glaucoma, kidney disease, heart or liver disease. And this is a good time to just generally remind you that if your patient has any diseases of the kidney or the liver, you really need to be checking their dosage of medication to make sure it has been corrected for whatever impairment they might have in those excreting organs. All right. So next medicine we're going to talk about is Buspirone. So notably, Buspirone does not help with depressive symptoms. It really is only used to treat anxiety or to augment antidepressants for anxiety control. Some of the biggest side effects are dizziness, insomnia, agitation, and nausea. So really not much different than your typical SSRIs or SNRIs. And the next class we'll talk about is Pregabalin and gabapentin. So these, some of the biggest side effects you need to be worried about initially when you're counseling patients on these medications is that they have dose-dependent sedation and dizziness. So making sure your patient is always in a safe place when they start them, and usually is at home prior to going to bed. That is generally the best time to start this medicine. Some other side effects related to Lyrica and gabapentin are headache, lower extremity swelling or peripheral edema, and weight gain. Again, I want to highlight caution in substance use disorders. It does have substance use potential or abuse potential, especially at higher doses. Notably, Pregabalin is a class 5, So that concern has been highlighted by making it a class 5 drug. However, gabapentin, there's some newer research and some like very preliminary findings that would suggest that it has similar risks for abuse. Next class would be benzodiazepines. So I think this is one that our patients ask us for very often, and I think it's good to have a good like stance, a personal stance on benzodiazepines and when you prescribe them and when you do not. I know personally I've relayed to my patients that it is not my clinical policy to chronically prescribe benzodiazepines, and if that is something they would like to take on a daily basis, that I will be referring them to a psychiatrist. And I think that's really helped me out and made me feel more comfortable talking with patients about benzodiazepines. So as far as acute effects, a lot of you guys are all familiar with this: drowsiness, ataxia, dizziness, behavioral changes. Chronically, actually, if you were taking these on a daily basis, there are some uncertain physiologic effects that we haven't fully bared out yet. But there's some suggestion that if you take these chronically for more than 6 months, there's an increased risk for dementia, and that cognitive defects that might present while taking benzodiazepines may not completely resolve after discontinuation. If you're able to avoid, and if you are prescribing benzos chronically, I would recommend trying to avoid those with a shorter half-life. Those have a higher risk for addiction and more severe withdrawal effects generally when you stop them. As a reminder, I put the mnemonic that I think we all memorized in med school on here, that your short actings are alprazolam, trazolam, oxazepam, and midazolam, so the ATOM medications. Your intermediate ones are TLC, temazepam, lorazepam, and clonazepam. And then honestly, I just remember that the rest are long acting after that. But I think it's definitely good to at least have a handle on what the short actings are, and know that you should generally try to avoid those. Benzodiazepines can be an appropriate adjunct in a patient who's going to be taking them short term. So prior to a big procedure, if a patient has a specific phobia that they're going to take the medication for, a couple times a month, maybe once a week, that is not so much of a concern because they're not going to develop physiologic dependence on it, and their withdrawal likely will not be severe, if even existent, in that case. So they are dangerous medications because you can have life-threatening withdrawal from them. So please prescribe them with caution. This next medication, we are going to talk a lot more about antipsychotics in the schizophrenia lecture, but Catiopene is an option to treat anxiety. It does have significant metabolic effects. You need lab monitoring. It's got significant side effects as well that the patient might feel, like anticholinergic, hypotension, sedation effects. You have to get EKGs in these patients for QTC concerns. And sexual dysfunction is pretty prevalent. So overall, this would not be go-to medicine almost ever for anxiety. And if I were considering this, I'd probably already have a referral out to a psychiatrist. All right. Another medication to consider is hydroxyzine. I think we see this a lot, and we use it a lot in the hospital and in the outpatient setting. Hydroxyzine, obviously it has those anticholinergic, antihistaminergic side effects that come with it, and we actually use that to our benefit pretty often. Drowsiness being the main one I think we take advantage of to help with insomnia. Dry mouth, dizziness, headache, confusion, especially in your elderly patients, are things to watch out for. These can be taken on an as-needed basis, and those side effects that I mentioned are generally temporary, time-limited effects. All Some miscellaneous medications, mirtazapine. That medication can cause weight gain, sedation, and dry mouth is pretty common. Imipramine, a tricyclic antidepressant, would generally not be my go-to, but it is an option to help treat anxiety, specifically of the tricyclic antidepressant class. Of those side effects that you could get, you've got a lot of just anticholinergic side effects. Sedation, hypotension, dry mouth, urinary retention, tachycardia are going to be some of your main concerns there. All right. So now you're following up.
Hey, Lauren.
Yep. Did someone say something?
Yeah. One of the staffing doctors told me that weight gain effect from Remeron comes from like delayed gastric emptying. And if you encourage your patients to pace their meals, it's not necessarily a metabolic effect as much as people just eat more because they don't feel as full. So I thought that was very interesting. If you counsel your patients, it's not like a metabolic thing that makes them gain weight. It's just they eat too much when they're on it. I don't know the truth of that, but I thought it was interesting.
So it kind of like, yeah, that is really interesting. Yeah, thanks for sharing that, Coop. All right. So now we've got anxious Andy coming back. He calls your office 3 days after picking the medicine up, and he angrily tells the nurse, the population health nurse, this medication is only making me worse. I can't sleep at all. I'm worried about everything. I may as well pick smoking back up. It worked better than these pills. After reviewing the chart, you realize that you started Andy on the typical dose of antidepressant instead of decreasing by 50%. It's no wonder he feels this way. So remember that Andy is an elderly gentleman. You started him on the typical dose for antidepressant effects rather than anxiolytic effects. And it wouldn't be surprising that the patient is having activating effects, including insomnia and worsening anxiety. In this particular scenario, I would probably recommend that the patient cut the dose in half or send in the 25 milligram pills, and would recommend starting it in the morning. The activating side effects do tend to subside over time, but we really need to make sure we're not giving a patient too high of a dose to start off with that would cause them to have those side effects so severely. All right, so next, anxiolytic failure and what to do about it. So similar to treatment of depression, our goals are pretty much the same. Toleration of the medication, remission of symptoms, and back to baseline functioning. If any of these are inhibited or not met, then by definition, the anxiolytic has failed. In regards to trialing the medication, 4 to 6 weeks of a therapeutically dosed medication is considered an adequate trial. Keep in mind that this is a little bit different than treatment of depression solely. For depression, we usually give it 8 to 12 weeks. This is about half that time, 4 to 6 weeks. So in my head, I'm thinking anxiolytic treatment is considered failure after about a month of a therapeutically dosed medication rather than 2 months. And reminder that therapeutically dosed means one, the patient is having either one, having a good response to a medication, even if it's at a really low dose, or two, is within the recommended therapeutic range for the medication. So for example, if the recommended therapeutic range for sertraline is, I don't know it off the top of my head, but if it is, 25 milligrams to 100 milligrams daily for treatment of anxiety, if that is the therapeutic range, then if you started a patient on 12.5 milligrams daily and they're doing well with it and they're getting a good response from it, then I don't know that I would consider it a bad thing. In fact, that could be a therapeutically dosed medication, even if it's not within the recommended range for treatment. However, if they are not within that therapeutic range of, for example, if this is accurate, 25 milligrams to 100 milligrams, and they're not getting a benefit, then that's obviously not therapeutically dosed. They really need to be within that target range in order to consider that a therapeutic trial. You also, if a patient fails an anxiolytic, every time they fail it, you need to be reevaluating your diagnosis or considering gene site testing. So if the patient is not responding at all, so you've done 4 weeks of a therapeutically dosed medication, you can consider switching to a different SRI. A reminder, intolerance of one SSRI does not mean intolerance of another. Sometimes it's appropriate to cross taper between medications, and I would always try to look this up. UpToDate usually has some good recommendations about how to cross titrate medicines or cross taper them, and how to switch directly from one to the other in regards to a dose equivalency. If someone fails 2 trials of SRIs, that might be an appropriate time to consider treatment with Buspirone. Would probably be my recommendation over Pregabalin, but Pregabalin is an option to try to treat their anxiety. And again, this is in the case that anxiety is the only thing that they're dealing with and that they're not dealing with depression as well. Patient has a partial response to medication. Consider augmentation with, again, same medicines, Buspirone, Pregabalin, which does have its own set of risks, but on UpToDate, that is actually still one of the second-line treatments that they recommended. And then Hydroxyzine was not listed on UpToDate site, but personally, I've found that it's very helpful, especially if their predominant symptom is insomnia. So I would always consider augmenting with those medicines. Those are especially helpful in a patient who's on an antidepressant that's helping their depression, but might not be helping their anxiety so much. All right, so say nothing works. They've tried a couple rounds of those SSRIs, SNRIs. They've tried Pregabalin or Buspirone. What do you do next? If they're, like I said before, if they're getting some extra benefit from those, an antidepressant, for example, it's helping the depression, but maybe it's not helping the anxiety so much, benzodiazepines are an option to help augment, but they generally would not be my first go-to. And if you're considering them chronically, I would refer to a psychiatrist. Adding on gabapentin, which has its risks, as we've discussed before, mirtazapine, Catiopene, and Imipramine. I think if I had reached this point, I would probably be, again, calling a psychiatrist before considering adding on those medicines that especially have a lot of side effects. I don't want my patients to feel like they're on too many medicines or like they have to cope with too many side effects throughout their day-to-day life, and I'd rather have a psychiatrist evaluate them. This slide again is a reminder about patient non-compliance. Patients started on, about half of patients started on an antidepressant will stop by 3 months. This is a big, big barrier, and almost every time I've asked a patient when they failed an antidepressant for treatment of depression specifically, they almost always say that they've stopped before the 3-month mark. And again, that's for depression, anxiety. Sometimes the trial needs to be just a little bit shorter. So you have to talk with your patients about what is constituted as a failure of medication. And again, this table on the right from the New England Journal of Medicine, I was a part of an article where they reviewed, barriers to patients complying with their medications. And top of the list, there is psychological problems. So that's really, that's a big thing. Side effects of medication is on that list as well, which we know antidepressants and any of the medicines we've talked about do tend to have. Patients' lack of insight, lack of belief in the benefit of treatment are all barriers that I think we pretty often see when we're treating patients for mental illness. Okay, so you're seeing anxious Andy again. He's here for a 2-week follow-up since decreasing the dose on his medicine. He apologizes for getting so upset over the phone. He self-reports improved anxiety, but he's still having trouble sleeping. It is no worse than it was before, I guess. He takes the medication each morning and it doesn't cause any drowsiness. His GAD-7 is 12, his PHQ-9 is 7. You discuss the expected timeline for improvement, stating that a 4-week trial of a typical dose is needed before stating that sertraline has failed. In the meantime, you prescribe a small dose of hydroxyzine, 10 milligrams each night to help with sleep. So important things to point out here. These activating, he did have some activating symptoms initially that have since improved, which is generally the expectation. Of course, you always want to be thinking about mania in those circumstances, but don't always assume that if a patient has activating symptoms like insomnia, increased anxiety, that it is mania, because it might just be a side effect from the medication. As far as his insomnia goes, that's better, but his anxiety is still persistent, though improved. His GAD-7 went from 18 down to 12. So I would say this is a partial response, and he's only 2 weeks in, so 4 weeks is definitely, I think, on the table for keeping this medication on. Helping him out with the some of the insomnia that he's got. I think hydroxyzine would be a good option. Up to date, and some other sources recommend using benzodiazepines in the short term sometimes, if you believe that the medication has induced some of those side effects of insomnia. So I don't think that's the case in this particular patient. I think he will continue to get better as he sees improvement with his anxiety, but benzodiazepines are an option in the short term to help out with some activating side effects. Okay. So next, talking about anxiolytic discontinuation. So when do you do this? You can consider treatment of anxiety to be adequate after about 12 months. So I think this is good to set a timeline with your patients that they may not need to be on this medicine forever. And 12 months is generally the recommendation. However, if a patient's has failed a couple times or has relapsed a couple times, that's when you could consider maintenance therapy for the anxiety. Again, remember that shared decision-making with your patients in those situations is key. And it is okay to consider discontinuing a chronically prescribed anxiolytic if a patient simply assumed they were supposed to be on it forever and really just never tried to get off of it once they became well. So that is okay. I do like to have those conversations with my geriatric patients because I do get concerned about polypharmacy in them. So as far as how to discontinue, most SSRIs and SNRIs should be tapered over 2 to 4 weeks. You can always slow down if you need to. Paroxetine and venlafaxine are those at the highest risk for discontinuation syndrome, which can have all sorts of manifestations, but includes things like dizziness, headaches, nausea, irritability, brain zaps I've heard people describe before. And then for benzodiazepines, I did a whole lecture on this last year, but you really should be tapering only as quickly as the patient tolerates. So there should not be a set goal or timeline for getting them off of it. If you're stopping a chronically prescribed benzodiazepine, you really need to be going pretty slow in that taper process. The patient can have a benzodiazepine withdrawal symptoms for up to months afterwards if you go too quickly. So in summary, as far as how to choose an anxiolytic, SRIs are your first pick. Give consideration to patient age, substance use disorders, gene site testing, and side effects. As far as anxiolytic side effects, SSRIs are the best tolerated. What to do about failure and what is failure. You need to be trying the patient on 4 to 6 weeks of the right medication, meaning a therapeutically dosed medicine. I would switch to a different SRI and then possibly Buspirone if you failed those. If you failed a couple different monotherapies, consider augmentation and then consider a third line agent. And then after 12 months of being on an anxiolytic, if this is the first time, you can consider tapering off unless the patient has a history of significant anxiety relapse. There's some references, they're not formatted perfectly, but they're available if you'd like them. Anybody have questions or comments?
That was a really good talk, Lauren, and I do apologize I missed the beginning, but I wanted to highlight what you were saying about SSRIs in the treatment of anxiety. I have also found that they're very helpful, but one of the things, and you may have said this already, so I apologize if you did, is that you have to titrate the dose. For anxiety, you almost always have to go much higher on the dose than you do for the treatment of depression. And I try to stay away from the more activating ones, because they just tend to make people more anxious.
Okay, yeah, that's really helpful because, yeah, I know most resources I was looking at say start really low because the activating side effects, but you're saying like ultimately titrating towards the higher end.
Exactly.
Yeah.
Yes. And thank you for bringing that point up. You do have to start really low, and that whole start low, go slow kind of mantra holds true, but you usually have to titrate to a pretty decently high dose to say that you have a medication failure.
Okay, thank you for that. And I was also curious to hear people's thoughts on using Buspirone PRN. I've seen that a few different times. I had a hard time finding information about that.
Hey, Lauren, Dr. E here.
Yeah.
Great talk, but totally agree with everything that you said, and you did a really nice job of kind of laying things out. One thing that I would just highlight again is just to make sure that when you're talking with your patients to really set that expectation about the timeline involved when you're up titrating the medicines. I think sometimes they get a little bit disappointed if they're not really feeling better right away, after that first appointment or maybe second appointment, but you're not really up to that therapeutic dose yet. So make sure you tell them to stay patient with it. So with regards to Buspirone, I've not had much success with Buspirone monotherapy. I think you highlighted that. Usually it's used as an kind of augmentative therapy for depression and maybe coexistent anxiety. I've never used it PRN, nor have I really heard of it used PRN. Maybe other people have. And then final question is, I noticed that Dylan Torgerson was in one of your slides doing some woodworking. Did you permission, to share his photo?
I actually think that wasn't Ron Swanson. That was a dang it, I'm forgetting his name. Chris Traeger.
Yeah, Chris Traeger was there, but Dylan was in the background.
Oh, was he? Oh, no, I did not get his permission. I don't know if he's on here. Sorry, Dylan.
Jocelyn has a question.
Thank you.
Yep.
Regarding what Dr. Bunch said about the activating meds, I know a lot of them are specifically for anxiety or do have that label. Does that eventually get better with the activation causing the anxiety, or will they always be a little bit more anxious with it?
So my understanding was generally that anxiety goes away. Or the activating effects do start to go down eventually. What I have read is that if a patient's having activating effects, you generally you can consider decreasing the dose or making sure they take it in the morning time as opposed to nighttime. I'm not sure about the exact timeline. In my head, I was thinking a couple weeks is when those effects would start to wane. Does anybody else have input on that?
I think that's generally true in my experience, but I have had some patients who have not had that waning happen, in which case, as we know, a lot of our patients, they struggle with anxiety, especially at nighttime. They'll wake up with either legitimate panic attacks or they really have a hard time shutting their mind off at nighttime. So it's kind of exacerbated by insomnia, inability to get to sleep. And so sometimes if you get to that case, you kind of have to jump ship or down titrate and do something different.
Thank you.
I agree, and about 2 weeks is pretty typical, as well as for a lot of the other side effects from SSRIs in particular, like headaches and GI symptoms and that sort of thing as well.
Hi, Lauren. Thank you for your talk. This is Kristen Steiner here. I wanted to kind of talk about the Buspirone since that was a question you had. I do have one patient that uses Buspar more PRN and has good benefit with that. Now, is it placebo effect? I don't know, but it seems to help the patient out and doesn't really hurt her. So I've just kind of continued it, but that's an N of one, I guess. So
Yeah. No, I inherited a couple patients who were on Buspirone PRN. It was a little unusual, but one of them had no benefit from it, so we stopped it. But the other one continued it. I just hadn't seen that before.
Hey, it's Cooper. Do any of you use SSRIs PRN for like PMS or PMDD? I've heard that that's one situation where they don't have to be on them chronically.
Yeah, I do. This is Dr. Schreiner. I do for PMDD. You can have SSRI use just for like 2 weeks of the month. Usually it's that week leading up to their period and the week on their period. The challenge is just sometimes I've had patients that we try it that way and it does work fairly well, but then they start to recognize the 2 weeks they're not on it, they're maybe not feeling as well as when they were on it. So in the long run, they usually evolve into just taking it all the time, but it definitely can work kind of short term. It's best to, like, Prozac is really good for that because of the long half-life. So you're not going to get quite the withdrawal that you would see if you abruptly keep stopping things every 2 weeks. So I would say it's not for every SSRI, but Prozac's a good one for that.
There's a question from Chris in the chat.
Oh, oops. Thank you. Chat. There you go. Oh, Chris was asking which SSRIs and which SNRIs are more activating. He thought Prozac fell into that category, but he wasn't sure about the others. I honestly don't know the answer to that question.
This is Dr. E here. Have to be honest with you, I think in my experience over the years, it's very much been across the board and sometimes individualized by patient. Generally, when you look at the studies, you always hear about Prozac, sertraline, sometimes Zoloft is a little bit more activating. But, you know, I've started patients on those medicines before and have not seen that side effects. So I don't know if anybody can quote an official study or reference. I can send down an email that I had forwarded probably a couple of years ago, but I found a website that does a comparison of different SSRIs and different side effects and patient scenarios that might be beneficial for one over another. And I'm happy to send that out.
Yeah, that would be helpful. Yeah. Okay. Well, if that's all the questions, thank you guys for the questions and comments. I really appreciate it. Yeah. All right. Well, see you guys soon about schizophrenia. So see you then.
Thanks, Lauren.
Thanks, guys. Bye.
Thank you. Good job.
Thanks.